At the Peter Lougheed Hospital in Northeast Calgary, you'll find some of Calgary's smallest and newest residents. As they learn to breathe and feed, their parents are encouraged to hold these newborns skin to skin against their bare chests. Studies have shown that skin-to-skin care is effective and helps babies to feed better. It helps babies to grow better, and it helps them to grow earlier, go home earlier, especially for the premature babies, compared with the gold standard previously of 24 hours in the incubator. Skin-to-skin care was popularized, and studies were done primarily in Colombia in the 1970s, where they were able to show that premature babies cared for against their mother's bare chests were able to stay warm and were able to survive. Of course, those studies were done out of necessity. There were no incubators, and electricity was scarce. Nearly 50 years later, we're now introducing skin-to-skin care in nurseries here in Calgary and in Canada. And skin-to-skin is now accepted as a best care practice for all newborns, whether premature or at term. Skin-to-skin is just one example of a simple, low-cost intervention that is introduced and used in a low-income setting, but yet is very useful in our high-income setting too. Now, the World Bank defines low-income or poor countries as those where people make less than $1,000 a year, which is just under $3 a day. On the other hand, high-income countries or rich countries are those where the average income is over $12,000 a year, like in Canada. So, what can rich countries like Canada learn from poor countries? Canada's contributed lots to global health, and in particular to maternal and child health. The great news is that a concerted effort towards global child survival has been successful. And when I started my pediatrics career in the mid-90s, more than 12 million children a year died under the age of 5 before reaching their 5th birthday. Now this year, that number will be less than half. While half, or 6 million deaths in a year, is still too many, it's exciting in global pediatrics. We're now talking about not just surviving, but also thriving. Most of my own global child health work has been with partnerships that the University of Calgary, Cumming School of Medicine has in East Africa. And you can imagine moving between the two worlds as I have. First, working at the brand new Alberta Children's Hospital. It's a state-of-the-art, highly technical facility, one of the best in the world, heavily resourced and a beautiful place, especially for sick children. On the other hand, in contrast, working alongside health providers in East Africa, in crumbling buildings with no electricity, often no running water, managing equally sick children, but with often not the essential medications and supplies that are needed. This stark dichotomy is hard on the senses. It's hard going back and forth, and it also calls to question what global health really means. Because I've been personally humbled, and I've been very inspired and enlightened by so many of the people that I've worked with internationally, especially those who have very little, whether it's health providers, communities, families, or children. I think my practice has changed amazingly because of the work that I do between these contrasting worlds, and I'm also increasingly aware of what our Canadian system could learn if we were able to look at those countries that have much less. Now, global health programs often involve the transfer of ideas and resources from rich to poor. But there's also a great opportunity for the opposite to happen. Learning that comes from poorer settings and countries to richer ones is sometimes called reverse innovation. And although it's not a new idea, it is an idea whose time has come, especially in health. Because our health system here in Canada is too expensive. It's not sustainable. We know that we have many highly expensive technological advances that offer amazing possibilities and amazing opportunities for people, but they're too expensive and they often lead to inequalities. what happens in our system is that we have expectations and systems that make it hard to go back once we've introduced a new treatment, a new test, or a new technology. In many ways, we're trapped in complexity and technology, and it's like we have a health system that's a Rolex, when what we really need is a Timex. Poor countries can provide an ideal laboratory for out-of-the-box thinking and innovations. A working with less approach demands creativity, and it often leads to simple yet low-cost solutions. Also, in low-income countries, often people are faced with fewer institutional limitations, and they have different expectations, so they're able to come up with interesting and innovative ideas. As a result, people who work in poor settings work differently with patients, they teach differently, and they work in unique ways with communities. The result is not necessarily lower quality. In fact, with skin-to-skin care, for example, it's quite the opposite. So let's look at some other examples of where I can highlight that we can learn and also adapt to our Canadian setting. Task shifting. So most poor countries are faced with terrible challenges of health human resources. And to be able to provide any kind of reasonable care to these huge volumes of patients, they need to shift tasks from expensive providers like doctors and nurses to lower cost and more available providers. And in East Africa, I've been privileged to work with lots of different types of healthcare providers, including those who often have limited education or training, but very focused training. And with that training, they become very competent to be able to provide care, often in a primary care setting or even in the communities. Sometimes they can do vaccines, they can assess sick children, they can even give medicines for simple childhood illnesses. I think in Canada, there may also be opportunities to accelerate task shifting if we're willing to look, especially in primary health care and in communities, to places who have tried different types of systems. There's also another kind of task shifting that I've seen. In East Africa, children who are admitted to the hospital must have a family member attendant with them 24 hours a day. And since nurses on the wards often look after 20 or more patients at a time, it's essential that those providers learn to give medicines, change dressings, and monitor their children. While it's obviously not ideal when you have complicated and very sick patients, I have seen that families who are empowered and able to take over some of these nursing tasks potentially enhance care, and it certainly makes the transition when you're going home much smoother. Here in Calgary, sometimes I hear from families who feel disconnected with the children while they're in the hospital. And while we're very lucky to have excellent nursing, I also think there may be aspects of care where we could adapt task shifting to the benefit of those families. Probably the most inspiring example of task shifting that I've seen relates to the work that I've been involved with volunteer community health workers. Of the nearly 7,000 community health workers that have been trained in Tanzania and Uganda within our programs, most are women, most have limited education, and all are selected by their own communities. We provide the training, but then these community health workers in turn promote health for their own communities, and specifically child health, by visiting families, assessing sick children, and they also share health messages in their own ways. So let's take a look. So where volunteers like these are active, there's been a dramatic decline in child deaths, illnesses, malnutrition, and their dedication and success is evidence that health does not need to be the exclusive domain of highly paid professionals. Here in Canada, where we once relied on grandmothers, neighbors, and elders for child-related advice, today Are there opportunities for us to tap into the expertise still of wise community members that we have, be it in faith communities, ethnic, indigenous communities, and our own retiree networks? I think there may be opportunities for task shifting and to promote health within our own communities in similar ways. As we struggle here in Canada with updating our complicated information technology systems, electronic health in Africa has leapfrogged. And mobile technology provides what's long been lacking there, easy access to health information. So even where there's no water or electricity, even where the literacy rates are low, and regardless of age, it's been remarkable to see how electronic health has been embraced. Women report their pregnancies, communities receive their health education, and community health workers report about outbreaks. These are all done now via mobile health technology. This pediatrician at your fingertips application shows an application developed by one of our Ugandan colleagues to help support rural health workers in his communities to manage sick babies. So you input the heart rate and some other essential information about your patient, and an evidence-based algorithm guides you step by step in the treatment of your patients. I think there's applications for applications like this in our setting. Now, every time a baby's born, 1 out of every 10 times, a newborn will require resuscitation. And quick action is essential in life-saving. At the Cumming School of Medicine, we have some of the best facilities for simulation training and the best equipment in the world. And we use this simulation experience through scenarios and mannequins like the one you see here to practice scenarios like giving the first breath to a baby who's not doing that on their own, and other important tasks. Dolls like these ones create lifelike experiences for learners, and they can, with all the computer equipment, etc., can cost upwards of $30,000. In East Africa, we build on the same simulation experience, but our partners use low-fidelity mannequins. So here's a low-fidelity mannequin as an example. Meet neonatally. She can be filled with water or with rice. She has a lot of the same features as the fancy mannequins, and her cost is about $75. And because of the experience we've had using neonatally, we've learned the value of mobile mannequins. We've learned that when there's not a risk of theft or of damage, you can leave these dolls out and they can be practiced on night and day. So there may be some value to having simple technology like this that could have applications for some of our populations who can't access our great simulation labs here at the Cumming School of Medicine. Oral rehydration. So oral rehydration might be one of the most remarkable stories of medicine in the 20th century. And it's also a great example of reverse innovation. Early in the 1970s, the only available treatment for severe dehydration due to diarrhea was intravenous. And at the time, more than 5 million people a year would die from diarrhea. Most of those were poor and they didn't have access to intravenous. So by the late 1970s, there was a team in Bangladesh who had come up with a solution, a simple combination of sugar, salt, and water that could be given slowly and continuously by mouth to treat diarrhea, dehydration, and save lives. And UNICEF promoted this in a very widespread way. Cholera programs picked up on it, and survival from diarrhea skyrocketed. Early in my career, I had a chance to see firsthand how successful oral rehydration could be, even in the most sick patients. I was at that time working in India and then in Uganda, and when I returned to Calgary, I tried to introduce and encourage my patients to also use oral rehydration because it seemed so logical. It was easier, it required less needle pokes, and patients could go home more quickly. However, I faced a lot of challenges, both from practitioners and from parents. Then and today, people still equate high-tech intravenous therapy as a higher standard of care. Fortunately, the use of oral rehydration has now increased at the Children's Hospital, and you'll find it used more widely. Oral rehydration and some of the other examples I've given illustrate only just in the field of pediatrics, what rich countries like Canada might learn from poorer ones. As our technology advances and our healthcare costs rise, we need to think, how can we keep our practices in check? How can we integrate the best lessons learned from around the world? And how can we accelerate the translation from some of these other low cost and simple technologies into our setting here in Canada? Well, we can begin by accepting that flow can happen in two directions, that there are things that rich countries can learn from if we're willing to look for systems and people who have less than we do. We also, for those of us who are practicing in a high-tech setting, can consider that despite the fact that we have an abundance of tests and treatments and technology, more is not always better. And we need to be willing to go backwards sometimes and try less sophisticated and more simple options. Within the Cumming School of Medicine, we can look for opportunities to engage our learners in experiences like the ones that I've had globally. And we can engage our own partners in low and middle income countries more equitably. We can ask them for their ideas instead of always looking the other way around. Finally, let's reframe the idea of global health. The world is increasingly global, and the future of health is global too. So the barriers to shared learning going both directions is really in our mindset, it's in the systems that we've created, and in our own expectations. I'm a strong proponent of good technology, and I've seen its amazing applications and its life-saving advantages in the patients that I've cared for here in Canada. I really appreciate the role it plays in our healthcare. But as we look for sustainability in our health system, we need to look to our partners in poor countries and use them as a common sense check to the work that we're doing. Helping children to survive and thrive globally means bringing all players on board. It means bringing all ideas to the table, incorporating the best practices from all countries and all communities, whether rich or poor. Thank you.